Hello, StrokeBusters community. Welcome back to another episode where we unravel the mysteries of strokes and cerebrovascular diseases. I'm Amy Quinn, your host, bringing you groundbreaking research and expert insights from the Institute for Stroke and Cerebrovascular Diseases at UTHealth Houston. Today, we are delving into a fascinating study exploring the intriguing concept known as the obesity paradox in patients with spontaneous intracerebral hemorrhage. Joining us are two esteemed guests, Dr. Jared Chen and Dr. Andrea Gaitan, who played integral roles in this research. Y'all are in for a treat as we unpack the study's background, objectives, and compelling results. The study, aiming to understand the association between body mass index, your BMI, and functional outcomes in patients with ICH, also explores the role of race and ethnicity in this relationship. So stay tuned, listen in, and feel free to share your insights in the comments wherever you listen to this podcast. All right. So to start off, thank you both for being here today on StrokeBusters. It is extremely important to kind of dive into these research studies for our audience and for the public at large to kind of understand what it is we do behind the scenes to make public health better. So to start off, could you provide a brief overview of the background and objectives of your study, especially regarding the concept of the obesity paradox that y'all discovered in these patients with the intracerebral hemorrhage?
So I'll let Andrea, since she's the first author on this.
The obesity paradox has been established in multiple other pathologies, and it basically refers that there is a protective benefit and a survival benefit among patients that are overweight or obese compared to normal weight patients. So there's a lot of data, as I said, for other pathologies like heart failure, COPD, but in terms of hemorrhagic stroke, most of the data has always been focused more to ischemic stroke. And the data that's available for hemorrhagic stroke is controversial. Some people have shown that it exists. Some people say that it doesn't exist. So that's the reason why we wanted to explore this, see if there was actually the obesity paradox in these patients. And I mean, we were able to use a very large group of patients, so that is very good because they all came from a multi-center perspective study. So
again, like Andrea said, obesity paradox. It's not a new concept, but but normally in patients who have ICH, you would think that the overweight or obese patients would do worse because they have all these other comorbidities. Right. But in reality, what we found was that the obese patients tend to have better survival. And so, I think that is interesting. And, we were lucky enough to have access to this database, ERIC database, out of University of Cincinnati. It's a 3,000 patient ICH database. With different ethnic groups, and it was a prospective study, so the data was very good.
Excellent. So real quick, let's just recap. Can you explain in simple terms what intracerebral hemorrhage is and why is it important to study its connection with body weight?
So ICH is essentially a bleed inside the brain parenchyma itself, and different from subarachnoid hemorrhage and subdural hemorrhages. These hemorrhages, the ICH, tend to have higher morbidity and mortality, and there's still not a treatment for this type of hemorrhage, and ongoing research are being conducted to try to identify a treatment for this type of hemorrhage. Why it's important to look at its connection with body weight, like I mentioned, um, normally you would think that obese or overweight patients would have worse outcome, and this study basically refutes that, and it kind of gives us a perspective as to how we look at predictors of outcome in these ICH patients. And eventually, this is something that may be used as not necessarily body weight, but these kind of connections, could be used as patient selection, and also to hypothesis generating in terms of maybe looking at the mechanisms in which BMI or body weight affects outcome, and through that mechanism, maybe we could explore some therapies that may target certain aspects of ICH.
Intriguing. So, the paradox of this obviously is, as doctors, you don't want to promote higher body weights. So, where do you go from here? After, this is the obesity paradox.
In terms of
Yeah. So how do you go from here to explain this to patients who might have experienced this type of hemorrhage and their, health goals, recovery, things of that nature?
Yeah, I mean, I think like in this case, like Dr. Chen said, it's not like we're trying to promote people to gain weight or to be overweight or something like that. That's not the whole idea of this. I think it's more to like now we know that there's like a protective effect of having like a higher metabolic, like a greater metabolic reserve. We're not sure how this works. This should be like another thing that we are going to and try to explore. And but yeah, so we could try to mimic like the protective effect that it's having, like these patients are presenting, but it's not like we are trying to tell people like, hey, you should gain weight because you're going to have better outcomes in case you have an ICH, because we know like there are so many adverse effects of being overweight, so patients should still try to maintain a healthy body weight.
Right,
That
exactly. Patients. So what we can say is, if you have an ICH and you happen to be obese or overweight, you tend to have a better outcome. But that is not to say that you should put on weight in anticipation that you will have an ICH. And
exactly.
certainly, um, being overweight or obese is associated with a number of other problems. So the risks here probably outweighs the benefits, and obviously, wouldn't recommend that.
Excellent. So your study also utilized data from the ethnic racial variations of ICH study. So focusing on a diverse group of patients, can you walk us through the methods that you employed to determine the association between BMI and these outcomes? So what were the primary, secondary outcomes you looked at?
Well, the primary outcome was the 90-day mortality among patients. Secondary outcomes included mortality at discharge, the functional outcome based on MRS scale scores of patients at the 90-day follow-up, and also some like self-reported health status that were based on questionnaires that the patients filled, also at 90-day follow-up. And also like the length of stay was also one of our secondary outcomes. And as you said, we were able to include a very wide like population. Like we had non-Hispanic Black patients, non-Hispanic white patients, and Hispanic patients, which of course strengthen our results because we can generalize them more. And that is very good because we are aware that there are differences based on race and ethnicity in many pathologies. In this case, we did not find a significant interaction between body weight and the race and ethnicity. but there was a significant difference in terms of mortality. Like the non-Hispanic white patients were the one that had the higher mortality rates at 90 days. So, I mean, that means that there are some ethnic and racial difference that we still have to discover.
Absolutely. You also mentioned age as a factor in recovery. Can you explain how age interacts with body weight and influences these outcomes as well?
Yeah, for age, so for age, what we found is that when patients were older, they were more likely to benefit from being overweight or obese. But this worked more like an exponential, like in an exponential way. Uh, it was not like, how do you explain that? What?
Linear.
Yeah, it was not linear. It was more exponential. And yeah, most of our patients were older. The median age of patients, like the overall cohort, was 60 years old. So most of them were older, but we did find like patients that were older benefit more from being overweight or obese compared to the normal weight patients.
Yeah, so basically the patients who are normal or underweight, if they are older, they have worse outcome compared to, patients of the same age but obese or overweight.
Okay, and did sex play any role in here? Is there any major determinations between male and female?
No, not that
Interesting.
good find. Yeah.
Yeah. So yeah, every study has its limitations. Could you discuss the limitations in your research and suggest areas for future investigation? So where do you go from here with your study?
I mean, I think like one of the main limitations from our study, which is similar to most of studies that like assess this obesity paradox, is the use of the BMI. Because we know that BMI, although it's an easy like thing to get, it may not be the best way to measure like the actual body composition, like the measure adiposity. So we should probably try to get some other measurements like waist circumference or waist hip ratio, and also like take into account like the cardiorespiratory status and fitness of patients. That could also be an important factor on this paradox. So yeah, I think that is a very important limitation that we should all keep in mind.
Yeah, so in terms of kind of future directions, like I mentioned a little bit before this, was that maybe explore what's the mechanism behind better survival in ICH patients for these overweight patients, right? Is there some sort of epigenetics or downstream signaling that might be important that drives this better outcome for these patients, and clarifying that pathway may give us targets for therapies in order to improve outcomes for these patients without needing them to become overweight or obese.
Was there any collaboration with other schools or programs or institutions?
Yes, of course. Obviously, Dr. Dan Wu from the University of Cincinnati, who was gracious enough to give us access to the ERIC database, and this has led to a number of projects, including this one that we're discussing right now. There was a study that I've done before, which is kind of very similar to this, but talking about smoking and using the same database, smoking and ICH outcome, and people who smoke tend to do better, and the thought is that it's to do with the anticholinergic pathway, and there's some animal studies that have been done looking at this. Although there's not a particular drug that's been, developed for for treatment of ICH as of yet. But, along similar lines, right, the recommendation is not to start smoking in order to have better ICH outcomes.
Yeah. So as a non-practicing medical layperson, the takeaway here is the research is based on your findings. You're trying to mimic or find out what is the catalyst for, okay, a higher BMI. Okay, we can maybe replicate this in a drug or a treatment, and study the smoking, how it affects the body. So, less gain weight and pick up a pack of cigarettes, and more, trusting the science to lead you down a path for treatment.
Yes, yeah, exactly. So, basically we are, making observations on ICH patient outcomes. And from those observations, then we can, it's an avenue for us to explore mechanisms that may, that may be manipulated through, by using various therapies, or, that in order to improve patient outcome. Does that make sense? So,
yeah, perfect sense.
That if we can clarify the pathway or the mechanisms on how patients can, how ICH outcomes can be improved, then we can have therapies that target these mechanisms or pathways. And in order for us to kind of explore these pathways or to screen which pathways may be important, these observational prospective studies allows us to do such things.
Excellent. And it's also the takeaways, when you find these paradoxes, these things that break the common rhetoric and advice, it's interesting to not always make these assumptions. And, especially for trainees or people coming into research, or even anybody just out there talking to their doctor, sometimes the things you think are the standard are not, and then you explore further. This is really neat. So I thank you both again for sharing your insights on this study. The research obviously adds valuable perspectives to our understanding of stroke and its complexities. So we appreciate your time and expertise.
Thank you very much.
Thank you.
And that's going to do it. We are wrapping up another enlightening episode of StrokeBusters. And a special shout out to our listeners. Thank you for tuning in. Your curiosity and engagement make this podcast possible. And as always, ideas and opinions expressed on this podcast are our own and are not a substitute for expert medical advice. Always contact your doctor before starting any program or therapy to make sure you're getting the best care tailored to your unique situation. If you enjoyed today's episode and want to stay updated on all things StrokeBusters, be sure to follow us on social media. Follow us on LinkedIn, Instagram, Facebook, and X at UTHealth Stroke to stay updated on upcoming episodes and share with colleagues, friends, and family. For updates and the latest news on the Stroke Institute, research, programs, events, and more, go online to uth.edu/stroke-institute. Don't forget to subscribe on Spotify, Apple Podcasts, or wherever you listen to your podcasts. Hit that follow button. Never miss an episode. We have some exciting discussions lined up for you in 2024. So stay informed, stay curious, and stay engaged. Thank you for being part of the StrokeBusters community. Until next time, take care.